Hello and welcome to the Joint Commission Resources Quality and Safety Network Accreditation Update. I'm your host, Gail Garbarino. The rate of suicide is increasing in America. Now the 10th leading cause of death, suicide claims more lives than traffic accidents and more than twice as many as homicides. At the point of care, providers don't often detect suicidal thoughts of the individuals they serve, and unfortunately, many times these individuals take their own lives. Timely, supportive continuity of care for those identified at risk for suicide is crucial. The Joint Commission's Sentinel Event Database has reports of 1,089 suicides occurring from 2010 to 2014 among patients receiving care, treatment, and services in a staffed around-the-clock care setting or within 72 hours of discharge. The most common root cause of suicide documented during this time period had to do with shortcomings in the psychiatric assessment. Clinicians in emergency, primary, and behavioral health care settings particularly have a crucial role in detecting suicide ideation and assuring appropriate evaluation. Behavioral health professionals play an additional important role in providing evidence-based treatment and follow-up care. And for all clinicians working with patients with suicide ideation, care transitions are very important. Much of what we know about the profile of individuals who have committed suicide and those who have attempted suicide comes from looking at the data compiled about suicide victims and attempts. The following are some factors that have contributed to suicide. Mental or emotional disorders, particularly depression and bipolar disorder. Up to 90% of suicide victims suffer from a mental or emotional disorder at the time of death. Previous suicide attempts or self-inflicted injury. The risk of suicide is twice as high as general suicide rates for 1 year following a suicide attempt. The risk is even higher the first few weeks immediately following a suicide attempt. History of trauma or loss, such as abuse as a child, a family history of suicide, bereavement, or economic loss. Serious illness or physical or chronic pain or impairment. Alcohol and drug abuse. Social isolation or a pattern of history of aggressive or antisocial behavior. Discharge from inpatient psychiatric care within the first year after, and particularly within the first weeks and months after discharge, and access to lethal means coupled with suicidal thoughts. There is, however, no typical suicide victim. Many times, individuals having these risk factors do not attempt suicide, and others without these conditions sometimes do. Therefore, there could be a danger in considering only individuals with these certain conditions or experiences to be at risk for suicide. It's imperative for healthcare providers in all settings to better detect suicide ideation in patients and to take appropriate steps to provide these patients with detailed screening, risk assessment, and treatment. Through the Joint Commission's new Sentinel Event Alert, number 56, detecting and treating suicide ideation in all settings, the Joint Commission aims to assist all healthcare organizations that provide both inpatient and outpatient care to better identify and treat individuals with suicide ideation. To access this new Sentinel Event Alert, visit jointcommission.org/sentinel_event.aspx. There you'll find suggestions to help you better detect and treat this patient population. And with that, stay tuned for today's JCR QSN program.